This is Dr. Demarchena, again with Aaron Cohen, and we're continuing our discussion of aortic stenosis. In the previous video, we looked at the normal pressure tracings. Let's remember that S1 occurs about right here, and S2 occurs right at the aortic valve closure. Remember, there's an A2 and a P2, but right now we're just looking at S2 as one. Now, we're going to go ahead and take a look at the hemodynamic abnormalities that occur with AS. So again, normally there's no gradient across the aortic valve. So the pressures in the left ventricle and the aortic valve are the same in systole. When you start developing aortic stenosis, however, remember that the left ventricle has to raise its pressure very significantly in order to be able to eject blood. So here we're going to start with a case of mild aortic stenosis. And in the drawing, we're not going to elevate the pressures in the left ventricle. Instead, we're going to show you a diminution of pressure in the aorta. So as you develop mild aortic stenosis, you start having a gradient that occurs between the left ventricle and the aortic pressure tracing. So the aortic pressure is significantly lower than it is in the left ventricle. Now, as we get more severe aortic stenosis, the gradient becomes more and more. And notice that I'm drawing the peaking a little bit further out because it's taking longer and longer for the left ventricle to be able to empty. So it starts off with like a squeeze that's like a mild squeeze, and then as it gets more and more sick, it has to eject longer and longer in order to eject the left ventricle. Now, as we get into very severe aortic stenosis, this occurs again, a greater pressure tracing and even a further duration of ejection before we get our diastolic decay. So if we were going to draw this in, if we were going to listen to this in a physical exam when we were auscultating the heart, the patient with the mild aortic stenosis would have a crescendo, decrescendo murmur. There would be early peaking, and it would finish before the second heart sound. So this is the first and second heart sound. As we go into moderate aortic stenosis, now we have a later peaking murmur because ejection is delayed even further. And as we go into severe aortic stenosis, then our murmur actually is like a crescendo murmur that we don't even hear the end of before the second heart sound. Now, with other aspects of the physical exam, we would be feeling the pulse of the carotid. And again, in a normal person, you have a pulse of the carotid that goes up and then drops down. But in a patient with severe aortic stenosis, the pulse is delayed and it's weaker. So we're getting more and more severity here. As you get into a very severe aortic stenosis, your pulse is delayed and it's weaker. And this is called pulsus parvus and tardus. Tardus is late, parvus is weak. In the PMI, in the exam of the point of maximal inflection, you would feel again your normal PMI. You feel like an upstroke and a downstroke. With a person with severe aortic stenosis, the heart is having a lot of trouble ejecting blood. So you feel a larger PMI, but more importantly, you feel a more sustained PMI. So it takes longer for the heart to eject, so the PMI takes longer to be moved. Now, on top of that, as you develop more and more aortic stenosis, you start getting hypertrophy of the left ventricle. And as you start getting hypertrophy of the left ventricle, you have resistance both to filling uh, because of the thickening, and so you frequently will start developing an S4 gallop. So the S4 can be auscultated near the apex of the heart, but it can also be felt. And so, very common in aortic stenosis, you feel like a bifid PMI. So you feel a palpable S4, and you also feel the sustained ejection of the PMI. Remember that the S4 occurs after atrial kick. Now, the thing we haven't talked about is where you listen to this murmur. And remember that this murmur is heard best in the in the right parasternal area, and it radiates up to the neck. And very frequently, when you listen to the murmur, you can hear it all the way to both carotid arteries. It can sometimes mimic a bruit from carotid disease. When you feel the carotid arteries, we talked about the parvis and tardis, but we also sometimes have a shaking of um, of the carotid from the high turbulence going across it, and this is called an aortic shudder. And so what you feel is like a low pulse that's delayed, but you also feel like a vibratory sensation across the carotids, which is caused by the turbulence. Now, the one thing we haven't talked about, because we talked mainly about adult congenital, is something that's called an ejection sound. And so normally the aortic valve opening is silent. When we hear S1, what we're listening to is mitral valve closing. But in patients with congenital aortic stenosis, which we haven't talked about at all, the valve is very pliable, but the commissure is never really formed. It just becomes like a little central opening in the aortic valve. So if I were to draw that aortic valve, it would look like a little circle with like a little hole in the middle of it. If I looked at it in long axis in congenital aortic valve, you'd see something doming. You'd see a doming of the valve because there's really no major aperture, and there would be a central hole. Now, because it's so pliable, that valve can actually cause a sound during ejection, and that's called the ejection sound. And it's really it occurs about this point, which is just slightly after S1, and it's a high frequency sound, and that's called the ejection click. Now, I'm going to clear this because I'm going to just talk a little bit about the second heart sound. Now, remember that when you look at a patient, listen to a patient's heart sounds, you hear S1 and you hear S2. But S2 is really A2 and P2. Usually in expiration, the A2 occurs right on top of P2 or slightly afterwards. But as you take a deep breath, you fill the right ventricle with more blood, and this causes P2 to move out. And so your pulmonic sound, or your P2, occurs after your A2. So this is still S1. So there's a separation with expiration. So if we look at this, this is expiration. I'm sorry. Let's clear that. This is inspiration. And this is expiration. Now, in a person with aortic stenosis, there's more and more delayed emptying of the second of the aortic of the left ventricle. As there's delayed emptying of the left ventricle, now A2 separates out because it takes longer and longer for the aortic valve to close compared to the right-sided pulmonic valve because it takes so long to eject the left ventricle. So in this situation, P2 now is way inside A2. And so when you take a deep breath, your P moves out again. And so it actually looks like they're both on top of each other during inspiration now, where P2 and A2 are right next to each other as one not affected. And so this is called paradoxical splitting of the second heart sound. Now, as you go from no aortic stenosis to mild aortic stenosis, you have paradoxical splitting. As the valve becomes more and more calcific, then it loses its pliability totally, and so you don't hear it moving or closing. And so then you hear an S1, you hear your late peaking murmur, and you hear no second heart sound. If you hear any second heart sound, what you hear is a P2, and you hear it away from the aortic focus, but over the pulmonic focus. So these are the stages of AS. Then in mild AS, you'll have normal splitting of the second heart sound. In moderate AS, you'll have paradoxical splitting of the second heart sound. In severe calcific AS, you'll have no audible second heart sound, or if you hear a second heart sound, it's an increased P2 that you hear over the aortic focus.